Everyone. So my name's Ibrahim. I'm one of the pharmacists here at St George Hospital. I'll just get right into this pretty quick because I know we are pretty limited with time. So in today's talk, I'll just briefly talk about emergency medicine from a pharmacy perspective at St George Hospital. The two classic services that we do, or the most common services that we do provide in the emergency department, so facilitating best possible medication history and discharge planning. And then we'll just give a quick medication update regarding three most common medications that we see, well, not most, but three common medications that we do see in the emergency department that sometimes do pose risks to our patients. So I'll just start off by a brief introduction about what we do. So the objective, I guess, of an emergency medicine pharmacist is to provide care, patients to optimize patient outcomes and continuity of care as they transition between the community and the hospital. We try to, of course, facilitate the best possible medication history as early as possible in the patient's presentation to try to enable rationale and timely therapeutic decisions to be made. We do try to also identify any medicine-related problems that may have contributed to the patient's presentation, and we try to discuss solutions with all relevant healthcare professionals, including yourselves. Best possible medication history. So as I said, one of our most common services that we do provide is providing or trying to obtain a best possible medication history. We do rely heavily on general practitioners to try to source medication histories. Unfortunately, though, what we do see a lot of is that when patients are presenting from their general practices, usually the medication list that they do have is not completely up to date. So I guess this is just an opportunity to remind you to have that chat with your patient. Try to update your patient's medication list upon their next visit, and always try to encourage them to hold that medication list, whether it be in their wallet, their phone, their purse, with them at all times when they are out. Just quickly give you a brief update about how it does affect prescribing rates in our emergency department. So recently we did do an audit of 420 patients, and we wanted to see how many patients actually brought in their medication list or their own medications. We saw that only 27% were actually presenting to the hospital with an updated medication list or with their regular medications. Now, how that affects our prescribing rates in the emergency department is that you can see the 27% that actually brought in their medications, almost 3/4 of them had their meds on time. They were prescribed without any errors or anything as such in the emergency department, versus the 73% that didn't actually bring in their medications. And we were seeing a lot of prescribing errors or delay in actually having their medications. So it does heavily affect our prescribing rates in the emergency department. Discharge planning. So just briefly, again, we are the ones that usually do initiate discharge planning by actually assessing whether the patient's able to manage their medications at home. The emergency department does offer a range of take-home packs of medications that usually we do give after hours when general practices are usually open and patients don't have access to medications. The take-home message from this is always just try best to carefully review the need to re-prescribing any pack that may have been started or initiated in the emergency department. One of the most common ones I just want to highlight or bring to your attention is the EpiPen. So unfortunately, in our emergency department, we don't carry authority prescriptions. So what that means is that usually we will provide the education necessary to patients that are started on an EpiPen or that are given an EpiPen. We do usually give them one EpiPen to take home with them, but we do usually require your assistance to provide or to organize further supply. This is just a quick list of all the pre-packs that we do give after hours from the emergency department, just to give you a brief insight. But two of the ones that I really want to bring to your attention are Endone and Panadine Forte. So recently, again, we did do an audit and we did call patients after they were given a take-home pack from the emergency department just to see how they were traveling with pain, whether they did require further analgesia. We did see that patients that were given packs of Panadine Forte, almost every single one of them had their GP prescribe a further supply of Panadine Forte versus Endone, where we don't really see that as much. So I guess take-home message is just be extra careful when you are re-prescribing these medications, assess carefully the need for them, and do know that usually when we are giving them, they're only given for a very short period of time just to treat that episode of acute pain. Medication updates from the emergency department. So as I said, we'll just briefly talk about three medications that we do commonly see that do pose risks or that we do see associated with risks or problems to our patients in the ED. The first group being the SGLT2 inhibitors. So we do see several presentations every week with patients with poorly controlled blood glucose levels that of course do require further investigation or treatment. Frequently these Medications more recently have proved to be extremely beneficial, especially in the setting of heart failure, since they can act as diuretics as well. However, they can lead to severe renal damage and euglycemic ketoacidosis. So what are SGLT2 inhibitors? So just as a brief reminder, they are oral medications that promote glucose excretion in the urine. They're used to treat type 2 diabetes. They do reduce glucose reabsorption in the kidneys, and they increase excretion in the urine. The three most common ones I think that you're probably all familiar with are dapagliflozin, empagliflozin, and erythrogliflozin. So they come as single agents and they do come as combinations, things like Cardiamet, Zigduo, Glactembi, all of these medications that are commonly used outside. So what are the risks associated with these? So the most common risk that we do see is severe DKA. So often this is associated with near normal or mildly elevated even blood glucose levels. So they're pretty hard for patients, I guess, to see or to detect when they are at home. When they're most at risk is when, well, what we do see is usually when patients are fasting, either for an X-ray, for a surgical procedure, for a blood test, anything as such, and they're not told to actually withhold their medication since they're not eating. The other risk that these medications do pose at times is impaired renal function. So very important, I guess, to always assess before you start these medications and during while the patient's actually on the treatment or on this course, the patient's renal function, since they do rely heavily on the renal function of the patient to actually work and do their NOACS, so newer oral anticoagulants, so they're not really new, I guess, anymore. Most people refer to them even as DOACs these days. The three common ones that we do see a lot of are apixaban, rivaroxaban, and dabigatran. The frequent problems, I guess, that we do see associated with these medications in the emergency department, we see patients that are using contraindicated medications, or we see patients that are using NSAIDs or anti-inflammatories or anything as such with these medications. We see often patients that have poor renal function and are still continuing the use of the NOACS. So it may have been appropriate when they were first started on it, but they haven't really been reviewed later on down the line. We see patients who may have these medications contraindicated for another existing condition, yet still on them. And at times as well, we do see inappropriate dosing. So dosing sometimes daily when it should be BD, or where it doesn't really meet the therapeutic guidelines. A very important note as well is patient education. So we do see a lot of our patients presenting, and unfortunately, without common knowledge or without knowledge, in-depth knowledge about these medications. So just to give you a brief insight, again, we did see about 350 patients at St. George Hospital recently. About 59% were on apixaban, 30% were on rivaroxaban and dabigatran, not so many, about 11%. We did assess the appropriateness of prescribing, so from an indication perspective, dosing perspective, and we did find that majority, so 72% were actually prescribed at a correct dose, but unfortunately still 26% were given a dose that wasn't the correct or the appropriate dose. Regarding patient counselling, again, you can see in green where the patients were counselled regarding the specific point versus the red where they weren't. So these were just assessed patients' common knowledge regarding why they were taking this medication, whether they knew what to avoid while they were taking this medication, and whether they were aware when to stop it and report to their GP straight away. So I guess it's just a very good reminder to have that chat with your patient before you do start them on a NOAC or when they are first prescribed on a NOAC. And if, of course, you don't have that time, make sure that you do refer them to their pharmacist at least to have that conversation with them. Last but not least is just the Ferinject, so iron carboxymaltose. We do still see, unfortunately, a lot of presentations to the emergency department where patients are presenting purely for the Ferinject or the iron carboxymaltose infusion. It is a medication that is available on the PBS at the moment, so it can be given in the community setting, especially in non-urgent cases. Recently, in the last 4 months, we did do a quick audit just to assess how we were tracking with the use of Ferinject in the ED. And what we did find was that out of the 62 patients that did present, 36 were actually, 36% were not, 36 of those cases were not urgent cases or not critical cases who could have actually had their iron injection outside in the community setting. So apart from the cost that's associated, I guess, with this, there is also time constraint that it does put on the emergency department because, of course, every patient needs to be registered, reviewed, charted, administered, monitored, and then have a discharge summary as well put together. Good emergency medicine resources. So I just wanted to quickly finish up with a few resources that are available outside, I guess, if you ever do need to refer to any resource. So we all are familiar with AMH, ETG, MIMS, and the most common ones, but There are other resources as well that are available that do provide some good information regarding medicines that are used in the emergency medicine. So things like your ASAM, your resus, avru.org. And I guess it is a good reminder as well, just to let you know that you can always come through the switch of the hospital and come through to the St. George Hospital Pharmacy. And I'm sure one of the pharmacists will be more than happy to help you out regarding information or counselling or anything as such for any of your patients about any medication that you might have there. And that's about it from me, I guess, this morning. Is there any questions? Sorry, there was a question about My Health Record, and we heavily rely on My Health Record. So I think the three main sites that we do often rely on are community pharmacies, patients' own medications or medication lists, GPs, and My Health Record are usually the sources that we do rely on. So if you do ever have anything that needs to be uploaded into My Health Record, feel free to do that, because we do often check that for all our patients as well.
Next presenter will be Christina, and I'll just change the slides.
Hi, my name's Christina. I'm one of the ED registrars. I'm just going to give you a brief talk on an interesting patient that came in about 6 months ago that we initially treated as a sepsis of unknown origin. So if I can get these slides to work. So she came in on a busy Monday night shift. And was triaged as a Cat 2 and placed on the sepsis pathway. The sepsis pathway involves them having to be seen within 10 minutes and getting fluids and antibiotics within the first hour. So her ambulance triage was that she was a 62-year-old female. She'd come in with pain to her left lower limb. She had maybe a swollen left ankle, and they were querying septic gout. She was reporting some pain that just travelled up to her shoulders bilaterally, and she had a past medical history of gout. On arrival, she was hypotensive. She was splitting between tachycardia and monitored in a regular rhythm, and then a sort of slower sinus rhythm. With the CDA, she'd be given 700 mils of fluid and 5 milligrams of morphine, and she had been quite settled after that. So she was initially offloaded into acute hall 2, and these were her initial obs. So she was hypotensive with a tachycardia of 146 that was monitored in a regular rhythm. She was a GCS 15 and afebrile. Due to her persistent tachycardia and hemodynamic instability, she was moved to resus. So a little bit about the patient. She's a 62-year-old female. She's of Tongan background. She was moderately overweight and had a past medical history of poorly controlled type 2 diabetes. She was known to suffer from gout, but hadn't had an acute flare for 3 years. She also had osteoarthritis and hadn't actually been to the ED since 2018, and that was just a brief presentation that didn't require admission for an osteoarthritis flare. In terms of her drug history, she had no known allergies. She was been on colchicine for the last 3 days for her gout. She was on allopurinol and was only on 500 milligrams of metformin daily and had Voltaren gel PRN. My slides. Okay, so a little bit about why she presented to hospital. So she said 4 days ago she started to develop left foot pain and swelling. Reports that the pain was similar to her previous gout flares. So she went to see her GP and was started on colchicine. She said she noted some improvement, but it wasn't getting better as quickly as it normally did. She'd been taking her colchicine as prescribed, was taking 1 tablet a day, and prior to presentation reported that she was having sort of 4 to 5 episodes of diarrhea. There was no blood in the stool. She had no associated abdominal pain, no nausea and vomiting, felt otherwise well in herself, didn't report any fevers or other infective symptoms, but came in because the pain wasn't getting any better. It was actually getting a little bit worse. And she had experienced some sort of right shoulder pain, then left shoulder pain, but didn't report any chest pain, shortness of breath or dizziness, and had otherwise been well in herself. So on examination from the end of the bed, she looked comfortable. She had had 5 milligrams of morphine. She was a GCS 15. She wasn't screaming out in pain. Obviously, her blood pressure had improved with a little bit more fluids, but she still remained tachycardic. She was monitored in an A-flutter AFib rhythm, but was requiring 6 litres of oxygen via a Hudson mask. She had no photophobia, no signs of meningism. She was afebrile. Looking at her left lower leg, it was pretty unremarkable. There was nothing major jumping out. She had some midfoot swelling with erythema lying over the skin, but no tracking. She had no obvious ulcers or signs of trauma. There was pitting edema to her mid-shin, but she had good range of movement of the ankle joint and it wasn't irritable. It wasn't hot to touch, and she had a palpable pedal pulses with a capillary refill time of less than 2. And it wasn't woody or tight. So when you examined it, you could move it around and it didn't cause her too much distress. This isn't her leg, but this is sort of what it looked like. So as you can see, it's just a bit swollen with some edema, but there was nothing major jumping out to say that this was a source of the infection. So the working ED diagnosis for her was that she was a sepsis of unknown origin, and it had been complicated by colchicine and metformin toxicity in the context of an AKI. She had mild LFT derangements, and there was some evidence of synthetic failure. She was dehydrated, and it was thought that her sepsis was driving the new atrial fibrillation. The source was unclear, as the joint didn't clinically appear septic, but there was no other apparent source of infection. Her progress in ED, she was given 3 litres of IV fluids. There was some improvement in her heart rate with intermittent reversion back to sinus rhythm. She was given 2 grams of kefazolin and some magnesium. Her shoulder and arm pain resolved with improvement, so it was thought it was just a demand ischemia, but she did have a persistent metabolic acidosis despite 3 litres of fluid resuscitation, and her lactate on the gas remained at 9. So as you can see, this is just a screenshot of her OBS while she was in the department. She never really got out of that red zone, remained persistently hypotensive with an associated tachycardia. Throughout the course of the day, she slowly dropped her bundle and dropped her GCS. So she went from a GCS 15, became more confused, became more delirious, and sort of dropped to a GCS 13 or 12. This is just a screenshot of her bloods. So she had a high sugar in the 30s, and so her corrected sodium would actually be 132. She had an AKI with a creatinine of 193. She had deranged LFTs and a CRP that you can see of 434. So obviously this lady was quite unwell, and we were just not too sure where exactly her infection was coming from. She was seen by multiple teams down in the ED, which is a rare thing with 4 or 5 consults happening downstairs. She was admitted under GMU as a sepsis without source. They again believed that the AKI was due to dehydration and sepsis, and the lactemia was due to sepsis, colchicine, and metformin. Ortho came down to review the leg. Again, they didn't think it was particularly cellulitic. She had some chronic skin changes. She did have a edematous ankle, but no crepitus, and there wasn't any palpable collections. So they suggested that we progress to a CT of her lower limb and do a full sepsis workup on her. This was her chest X-ray. As you can see, she's a bit of a bigger lady, but there wasn't anything remarkable on the chest X-ray. And this is some screenshots of her CT of her ankle. So I don't know how well you can see it, but there are lots of little pockets of gas within the tissue, particularly around the midfoot. And these are your telltale signs for necrotizing fasciitis. So she was re-reviewed at 1 o'clock and she deteriorated considerably. The report on the CT said she had diffuse subcutaneous gas. There was progressively worse swelling. She was now on inotropes. She was confused, and she was consented by the vascular team for OT and debridement. This is just a screenshot of her op report. So she had necrotizing fasciitis of her left foot. On the presence of incision, she had a sort of dishwasher-like fluid with extensive necrosis. and lots of specimens were sent for culture and histology. And unfortunately, she went for a below the knee amputation. Her micro came back as 4 lots of positive blood cultures for Staph aureus. The tissue cultures came back as, again, Staph aureus, along with the deep wound swabs. In ED, she received Fluclox and gentamicin as a sepsis on unknown origin. She was then upgraded to TAS, Vanc, and clindamycin. And once the sensitivities came back, she was placed on meropenem, vancomycin, and Fluclox. And she was also given some IVIG for a presumed staph toxic shock. So just a little bit about neck fash. It's something that's really rare, but we do see every now and then in the ED and needs to be diagnosed urgently, and can only be diagnosed via surgical exploration. So it's a infection of the deep soft tissues that results in progressive destruction of the muscle fascia. Initially, like this lady, the overlying tissue can appear unaffected, so it is very difficult to diagnose. It's got 2 categories: your polymicrobial, which is type 1, which is the most common, and that's what's seen in your Fourniers. It usually occurs in the older population and those with underlying comorbidities, with diabetes being an important predisposing risk factor, especially those with peripheral vascular disease. You then have your type 2, that's caused by the group A strep or beta hemolytic streptococci. And in 50% of these cases, there's no clear portal of entry, and this one can happen in anyone. So this lady was type 1. She was a bit older. She had poorly controlled diabetes and probably a peripheral neuropathy. Risk factors for neck fash, so any sort of major penetrating trauma or sort of blunt injury, musculoskeletal injury with a skin break. Recent surgery, if they are immunosuppressed, whether due to chronic medical conditions such as diabetes, cirrhosis, HIV, or immunosuppression with medications such as steroids and chemo. Obesity is a risk factor, as is malignancy and alcoholism. So this lady, obviously, she was diabetic, she was obese, and she potentially may have had a strain to the ankle that she wasn't aware of at the time. But diabetes is probably the most important risk factor for lower limb, head and neck, and perineum infections. So clinical manifestations, it usually affects the lower limbs greater than the upper, and they normally report severe pain that's usually out of proportion to your examination findings. Obviously, this lady was a bit of a curveball because she was a poorly controlled diabetic. She had a peripheral neuropathy, and she reported some pain, but she wasn't screaming out in pain, which they normally do for the examination. 50% of them would have crepitus in the joint, but she was reviewed by multiple teams, and at no point did she have any crepitus despite having a lot of subcut gas within the joint. It's usually something that presents acutely, so it happens within hours rather than days. And you get edema, you get erythema. It's very difficult to diagnose from the surface. So bloods are usually non-specific. You should suspect it in any patient that has a sign of a soft tissue infection that's systemically unwell, i.e. this lady, she had a lactate of 9, she was unresponsive to fluid resuscitation, and she progressively got worse, requiring inotropes with a reduced GCS. It can only be made, as I said before, via surgical exploration, and radiology can be helpful, with CT being the gold standard, but it shouldn't delay surgical exploration. This lady progressed to a CT because we weren't actually sure where her infection was coming from. This isn't her leg, but this is like what it looks like in theatre. So you've got sort of a swollen and dull grey appearance of the fascia. There's this thin exudate without clear purulence. So as they said, she had this sort of dirty dishwasher-like fluid, and the tissues are often easy to dissect with blunt dissection. So I think they went in trying to save her leg, but it had progressed too far that she needed a below-the-knee amputation. So treatment for neck fash, if you use antibiotics alone, it's 100% mortality. You need early and aggressive surgical exploration and debridement of the necrotic tissue. They're usually started with broad spectrum antibiotics, and then once the cultures come back, they can sort of tailor the therapy. IVIG is given in toxic shock suspected patients, and this lady did receive 2 doses up in ICU. So this is just the ETG recommendations for antibiotics, along with the IVIG. So they did find that giving IVIG reduces the mortality rate from 33 to 15%. So the outcomes of NECFAS, there's a considerable mortality despite giving early and aggressive treatment. The lady was a type 1, so there's a 21% mortality rate. And then these are just some of the other ones. Predicted for poorer outcome, age over 60, serum creatinine greater than 2, as was obviously 177. Infections involving the head, neck, thorax, or abdomen, or any delays in surgery. The outcome for this lady, so she actually survived the operation. She didn't require any more debridement after her below-the-knee amputation. She did, however, have a 5-month stay in hospital. Her admission was complicated by ICU deconditioning. She then had recurrent gout flares whilst on the ward with poorly controlled sugars, pressure sores, and she had some upper limb neurology. She also didn't have residency, so there was a bit of an issue in trying to get her into a rehab facility to get her back to her baseline. So a few take-home messages, I guess. The most important risk factors are diabetes and peripheral vascular disease, because we're always taught that pain out of proportion is the main thing with NECFAS, but in these individuals, obviously, they don't present that way. So we always think if your pain is out of proportion, that's how you normally suspect it, if there's any crepitus or an acute deterioration. But I guess for you guys to consider in cellulitis patients or patients with soft tissue infections with risk factors, particularly diabetes, that aren't getting better, just to send them into ED for an urgent referral for surgical and medical review.
Morning, everybody. My name is Murali Krishna, one of the consultant from St. George University Department. After an interesting talk from the pharmacy and the clinical case, I will talk to you about a few things which will improve the interface between the primary care and tertiary institution. It will also give you a lot of resources which will help you refer and manage patients as you see them. The education program fits into a group's aims, which are as follows: provide a supportive framework for GMOs to produce appropriate transfer of care summaries, with an emphasis on improving communication during the patient's transfer from a tertiary institution to general practice. Support general practice in navigating the tertiary institution and implementing cultural change. Improving care provided to patients with chronic disease within Southeastern Sydney local health district. And also facilitate and improve the interface between primary care and tertiary institution. A few things which we want to see early: possible ischemic stroke, active chest pain, very high risk ACS, and mildly unwell elderly. Ischemic strokes, they get thrombolized or called retrieval. Thrombolysis within 4.5 hours, but can be extended to 9 hours depending on the imaging and depending on the patient. Clot retrieval up to 24 hours. And Prince of Wales is our main clot retrieval center. In terms of active chest pain and ACS, they need to come in straight away. But there's also pre-hospital activation of primary angioplasty, which is an ongoing thing in the New South Wales network. And mildly unwell elderly, because they're the ones who get septic and have a high mobility. We would love to see them early and sort them out. For geriatrics especially, there's different management options, which I'll talk to you about in the next few slides. Just the usual thing, what you guys know: look at the face, weakened arm, slurred speech, and time, because time lost could be lost brain. Services we can't offer, basically the hand surgery. If injury of tendons includes forearm, and St. John Hospital surgeons feel non-indemnified to deal with hands. Hand services provided at Sydney Hospital, except for a multi-trauma. That's a number you call and pays the hand rush. I'll give you a bit more information on that. There are a few things which we need to consider here. The hand referrals are 3 types. One is an emergency referral, urgent referral, and routine referrals. The emergency referrals are mainly deglowing injuries, infections, crush injuries, amputations, and those are stuff which needs to be discussed with the hand reg in Sydney Hospital straight away. And that can be referred either straight away or, if necessary, book an appointment in the hand clinic for next day. Urgent are the ones which don't need to be spoken to hand reg, but can be sort of discussed with the hand clinic for appointment, or you can send a referral, which we do it on EMR, but you guys can do it either written referral, which can be faxed, or could also be done through your online hand hospital form. These are for closed fractures and for a review, laceration, which is it's a review in a few days' time. The routine reviews are the ones which are chronic fractures, opinion on dependence contracture, Carpal syndrome, and other trigger finger and stuff, which will be reviewed every day by the hand reg, and they prioritize the appointments, and then which will be considered as a priority and will be done within 30 days or within 90 days or within a year. So if there's any discrepancy in you trying to identify which is urgent, which is routine, and you can call the hand surgeon, hand reg, who's on call 24/7, and then discuss with them, and they'll be able to guide you and can be discussed there. Service available for pediatric surgery here. We have a pediatric surgeon, so general and urological surgical patients, including torsion, less than 12 years, are transferred to Sydney Children's Hospital. For torsion age 12 and below, please refer to Sydney Children's Hospital directly, and please don't send for ultrasound if you consider it as a torsion, as it is time critical. For other surgical cases, we have a local surgical review prior to transfer, and we also offer orthopedic plastic surgery except hands and ENT and some neurosurgery, which gets seen here and get admitted here in St. George, based on the patient and type of cases. Ophthalmology, readily available, followed by 24/7 via Sydney Eye. The eye registrar will attend ED for emergencies only. Limited eye clinic appointments at the St. George Hospital. Serious eye problems are best referred directly to Sydney Hospital. Advanced imaging. We have a few issues with ultrasound and MRI. There's only one quarantine ultrasound slot each day for our ED. Studies are prioritized as category 1, 2, and 3. Once guaranteed the same day between 8:30 and 5. No routine weekend or public holiday ultrasound. Approximately 2 callbacks per week. And they're unable to make bookings after hours. And there's, in terms of staffing, we have variable ED bedside ultrasound skills. Some are good in one, some are good in other. But in terms of soft tissue, musculoskeletal, and vascular, it's variable skills. Definitely no quarantine ED MRI slots. Most outpatients referred by ED to private scanners. Sciatica with sensory deficit not considered to be urgent for MRI by neurosurgery or radiology, and book scans are often gazumped by emergencies. What happened here? Orthopedic services which we can't offer. Unfortunately, there's no dedicated fracture clinic, no fiberglass casts, no readily accessible physiotherapy clinic. There's limited but improving ED soft tissue injury physiotherapy service during our office hours, and essentially no access to soft tissue ultrasound. I'm not sure whether you can see this properly. This is just a cost variations for a few of the orthopedic management equipment, the cam boots and splints, which has non-refundable and has to be paid by the patient before it's applied. Dermatology is another service which we don't have an on-site consultant and on-site service. It's very minimal. There's Dermatology available between 8 to 4 on, supposed to be on Monday to Friday on a variable in a variable scenario. If they're busy in the clinic, they may not be able to come. But all consultation occur after hours by telephone with principal hospital with the on-call dermatologist. Dermatology or ID are potential alternate avenues for consultation if they could be related to them. Specific conditions which can be managed as an outpatient. These are from the clinical business rule from local health district. Example is NR 529 with no bleeding. They're considered as a low risk. You can withhold 1 or 2 doses of warfarin, key vitamin K 1 2 milligram orally. If INR less than 6 and there's no bleeding, vitamin K usually is not necessary. And you can follow up as an outpatient with repeat INR in 1 to 2 days. Could be like 20 to 24 hours if high risk. Other diagnoses which could be managed as an outpatient, I'll just run through a few. DVT, very limited access to ultrasound without admission, as because the quarantine slots are not available for AD, only 1 per day, and nothing on the weekend, kept in only for emergency like torsion or ectopics and stuff. Low risk P could be managed with a PERC rule and a negative D-dimer if you're considering PE. Other few diagnoses which could be managed as an outpatient are incidental AF, red control, newly diagnosed abdominal masses, pulmonary lesions, soft tissue, foreign body, and abdominal routine blood tests. This, of course, relates to the clinical scenario and the patient and a lot of other things. There's no blanket rule for this sort of diagnosis. There are avenues how to avoid ED presentation. We've got a few resources which could be used. I'll go through a few of them. Early pregnancy problem service, ambulatory care unit, medical admission unit, direct private geriatrician phone call to team or ED admitting officer to streamline ED journey. In terms of the early pregnancy problem service, apologies, this is a little bit of an older slide. There's a timing is wrong on this one. It's 7:30 to 8. The St. George Maternity and Women's Health Outpatient Clinic offers this service for assessment and further management of women with bleeding and pain in early pregnancy. Can be referred by ED, general practitioners, specialists, and other clinics. The referral criteria is just in the women in the reproductive age group, bleeding or pain, suspected or possible pregnancy, less than 12 weeks of amenorrhea, and if urgent admission is not needed. Where to refer? It's the Maternity and Women's Health Outpatients, first floor, Pritchard Wings, St. George Hospital, Kogra. Clinic times, it's Monday to Friday, it's 7:30 to 8. And the patient has to be there definitely at 7:30 if she has to be seen on that day. If you can get bloods and ultrasound done prior to presentation, that'll be very useful. And if you're concerned about ectopic pregnancy and if she's bleeding excessively, please send them to ED. Ambulatory care unit, mainly for diagnostic or therapeutic procedure, day only admission. It could be used for review of chronic conditions, but very limited scope because of the workload and other departments are extremely busy. INR reviews, iron transfusions, blood transfusion, all can be done as the ambulatory care unit. The therapeutic procedure could be even draining of ascites, and the gastroenterology department are happy to facilitate that. All you need to do is a fax form and if possible, talk to them. This is the ambulatory care contact information, this phone number and fax and other contact thing. For geriatrics, especially, we have a lot of avenues. It depends on whether you want to admit, whether you want to review, whether you want an outpatient consult. There are a few possible pathways. For hospital admissions, if sending to hospital for behavioral management and you would like a direct admission to the ward to avoid ED, you can call RAU, which is Rapid Assessment Unit consultant, through switchboard, and who can also advise you on MAU admissions, but always include health summary, medications, advanced care plan or directive if known or discussed with patients. For residential aged care facility patients in the St. George Hospital catchment, needing acute review, or think about sending to hospital, your first port of call would be good to go with the geriatric flying squad. There's a mobile number, 7 days a week, Monday to Friday, 8 to 8:30, and Sunday public holiday could be 10 to 6:30. Leave a message if no answer, and they'll get back to you. GFS can manage cellulitis, pneumonia, and CCF, and with IV antibiotics and IV diuretics. They can also get involved with the end of life and palliation medications. For residential aged care service facility patients needing subacute review, which means they just have general geriatric issues, behavioral management, capacity, etc., you can refer to a staging geriatrician. For outpatients or clinics, there's a clinic review. There's a geriatric outpatient clinic, but the wait list is quite long, 3 to 4 months. Please request first available on the form. If urgent, please call rooms to discuss and explain to the geriatrician as to why you need an urgent review. And there's a number there. Again, it's very important to include the health summary, reason for referral, medication, recent investigation, including a cognitive assessment or imaging and advanced care planning. Home visits, the St. John Hospital catchment. If patient unable to attend clinic or needs home visit, refer to Calvary Community Registrar. There's a fax number which you can do. It's 95533481, which you can fax, then get that organized through Calvary. Medical admission unit. This is suitable for patients with a 50% or better chance of being discharged in 48 hours. It allows front-loading of care in terms of senior review, diagnostics, and 7 days per week allied health cover. MAU is mainly for non-critical undifferentiated patients, elderly falls with comorbidities, and back pain with no red flags. Patients can be admitted directly, fast track from triage, ambulance bay, or ED beds. It's a dedicated phone number from 8 to 6:30 or 7 days a week, which can be contacted even by you guys if you're comfortable, and speak to the MAU consultant on. And these people can be flagged at triage and sent direct from triage to MAU if there are beds. Hospital at home is a new thing. St. John Hospital catchment only. For referrals, go speak to the HIT consultant or on the mobile between 8 and 4:30 p.m. If after us, you can call the switchboard and ask for the HIT nurse. The criteria is the patient be clinically stable. They could do cellulitis, warfarin management, but they only do BD. They can't do TDS and OBS or TDS treatment. It's a patient has to be independent or has carer who can answer the door. Respiratory Care Coordinated Program, the community-based respiratory program, mainly run out of St. George Public Hospital, focused on reducing hospital presentation, reducing unnecessary admissions, and improving the patient's quality of life. The team consists of respiratory nurses and physiotherapists who conduct home visits, reviewing respiratory patients living with both chronic and acute respiratory conditions. If you have any patients you wish to refer to the RCCP for ongoing review, you need to please complete the referral form and fax it to the access and referral team at St. John's Hospital on the fax number. I haven't put any of the forms as an attachment here, but I'll send it to you guys tomorrow, including the jury's forms and then the RCCP forms and the EPPS forms. Cardiology, they do consider it reasonable if a patient has an exercise or atypical pains to be commenced on aspirin and reviewed by cardiology as an outpatient without transiting via AD. And if you have someone with a new AF with minimal symptoms or compromise and no obvious cause, they're happy to have beta blockers for rate control and to commence on anticoagulation pending cardiology review and echocardiography if there's no contraindication and the patient is the right group. In terms of anticoagulation, could be anything. Could be rivaroxaban, could be apixaban, could be or Eliquis, or even dabigatran, depending on renal function and the patient physiology. Giving a summary, St. John's Hospital ED has a very high admission rates. We got great support from local GPs. MAU, SEU, and EPPS are potentially underutilized. Advanced imaging availability is limited. Certain subspecialty conditions are best referred directly to other institutions. Team engagement, prior to sending patients to ED, streamlines care. You can call the admitting officer on 91131744 for all the information. You can fax things to us, and we can take it from there. And consider deferring less acute referral during non-peak periods, which is probably the mid-morning and then late evening. This is a health pathways link, which was given to me by the renal and hematology team. You can register yourself, log in, and have your own username, password, and look through different departments. They have their own pathways for acute and chronic disease and how to manage diagnostics required, labs required, and in terms of management as well. This is only for other departments, not for MN's department. The link for health pathways, that's a good one. And also the number to ring to discuss at admitting office is 911317.
There are no more questions at this point. Thank you very much, everyone, for